Good afternoon, everyone. Welcome to this webinar entitled Sideline Ultrasound, presented by Dr. Jeremiah Ray. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to utilize ultrasound for the sideline emergency management and identify life-threatening and common sideline emergencies. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Jeremiah Ray and Darcy Belito de Luna have no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering questions until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Dr. Jeremiah Ray.
All right, good morning. Is my PowerPoint coming through?
It is.
Excellent. I'm Jeremiah Ray. I'm the head team physician at the University of California, Davis. Welcome to the Sideline Ultrasound webinar. As Darcy mentioned, I have no disclosures, although I'm looking at my student loan bills and I'm kind of thinking maybe it's about time to get some disclosures, pay those bad boys off. I'm a team physician in the Big West Conference and Big Sky Conference. Before I give my talk, I want to introduce a concept to you, and many of you probably are aware of it. Some of you might not be aware of it, but it's called FOAM. It's the idea of free open access medical education, and it was really developed by this Kiwi who is an emergency medicine physician and critical care physician who practices in Australia. And it's the idea that our medical practices are currently and ever-changing. They're evolving all the time. And if you want to read a textbook, you can get information from about 10 or 15 years ago. If you want to get information from about 5 years ago, you can read a meta-analysis. But really, keeping up with the greatest and latest information involves a lot of work by our colleagues and peers. And so what I tried to do in this talk, I tried to incorporate as many of these FOAM websites, these free open access medical educational websites as possible, so that you can use these as resources moving forward. And so you'll see lots of photos and lots of website links, and these are all free open access spots. So if you don't remember anything from my talk, that's okay, because hopefully you'll remember that there's free access to this on the internet. Now, my grandma says I have the gift of gab, and here you can see my head football athletic trainer actively sleeping in the middle of a football game on the sideline as I'm speaking with him. I did my very best to keep this pretty exciting and pretty fresh. We're going to go over a lot of information. And I think this information is going to be pretty exciting for you. So I derived the content of this talk from the times when I was covering events, and I really, really wanted to know an answer. So this is not going to be super useful right in the clinic setting, but if you're ever doing event coverage, sideline coverage, or if you ever have athletes coming into clinic from events and sidelines, I think this is going to be right in your wheelhouse. Part of the talk is going to be trauma-based, but part of the talk is really useful for just people exerting themselves. I got to tell you, some of the most exciting ultrasounds I've done on the sideline have been actually at marathons and cross-country events where there's no contact whatsoever, and you have a collapsed athlete and you want information as soon as possible. To start off, I want to re-emphasize what Dr. Finoff and all these smart people described as sports ultrasound. They didn't call it musculoskeletal ultrasound. They didn't call it joint ultrasound. They called it sports ultrasound because really, when you're a sports medicine provider, you are doing so much more than just looking at joints, muscles, ligaments, tendons, and bones. Our ability to take the ultrasound around with us to games, to sidelines, to events is really easy. Even with these laptop-based devices, you can throw these in your backpack and have them on the sideline. And it's getting even easier. Right now, there are 4 commercially available products that I'm aware of. I'm sure there are more that just fit in your pocket. Or if you want to be super cool like Chuck Norris, you could throw them inside your fanny pack and just take them to the sideline with you. Let's get on to the first topic of conversation. It's the FAST examination. Now, the FAST examination stands for the Focused Assessment with Sonography in Trauma. Now, in the United States of America, we really adopted this in the 90s, right around 1995 is when it really became a point of assessing the trauma patient with ultrasound. However, in other parts of the world, they've been doing this since 1971. And for those of you who remember the wonderful song, Joy to the World, and I know this song very well because my first name is Jeremiah, and there's that one part of it, Jeremiah was a bullfrog. You guys know what I'm talking about. Well, that's from 1971 too. So the rest of the world was pretty far ahead of us in the United States of America. Let's get on to what the FAST examination is. Focused Assessment with Sonography in Trauma. What this is useful is for identifying 200 milliliters of intraperitoneal fluid, pericardial fluid, or a hemothorax in the setting of blunt torso trauma. Now, football players, rodeo competitors, skiers, there's so many variety of sports where just normal sporting events, you absolutely can have enough forces transmitted to your torso to produce positive findings. Now, in a MD hand who's been trained, and we'll talk about training soon, the sensitivity is on the very, very low end, reported at 62. Most of the studies are actually in the 90s as far as sensitivity. And the specificity in the right setting, so if you have a previously healthy human who then was hit in the torso and you see free fluid, that is pretty specific for intra-abdominal blood. Here is a quick summary of some of the sensitivities and specificities reviewed in this 2017 meta-analysis. And what you see here, this is the diagnostic performance of the FAST examination in the ED. So diagnostic performance means identifying intraperitoneal free fluid, intrathoracic free fluid, or a pericardial effusion. So here you see sensitivities here, specificities here, positive predictive values, negative predictive values. We'll talk about the eFAST in a little while, but this is pretty cool stuff. The eFAST identifies a pneumothorax. The E stands for extended. So the sensitivity on the very low end, this is not a really reproducible number. Most of the sensitivities are higher than this. Specificity is quite high. Positive predictive value nearly 100, negative predictive value nearly 100 as well. Now, some of you who are not emergency medicine boarded like myself might be a little bit leery of this type of ultrasound. However, I want to show something to you. This is EMTs using point-of-care ultrasound out of the hospital. So these are just good old EMTs, not even paramedics, in the field using ultrasound to identify these emergencies. And what they found in these EMTs, you have a sensitivity, 61%. That's not too bad for non-healthcare providers. Excuse me, they are allied healthcare providers, non-physician providers. Specificity still is very great. And then the positive predictive value, when you see free fluid, that's very likely to be blood. And the negative predictive value is also pretty great. So in untrained, non-medical experts, I mean, this is pretty good stuff. So please have a lot of confidence moving forward with using this on the sideline ultrasound. How do you do the FAST examination? So it's a rapid 4-view evaluation for intraperitoneal, pericardial, and hemothoracic fluid. Now you can use two transducers. You can use the curvilinear, or you can use the phased array, also known as the cardiac transducer. The reason we select these transducers is they have a great degree of penetration, allow for a lot of depth when evaluating intra-abdominal organs. The high frequency or linear transducer gives you really crisp images up to about 5, maybe 6 centimeters depth, and that's just not enough depth for the studies we're going to be doing. My personal favorite is using the curvilinear transducer. With that, you can have excellent views, you can have a nice broad footprint, and you can switch over to the phased array or the cardiac transducer when you're looking at the heart in a couple of scenarios, and we'll go over those shortly. So in the setting of a patient that is laying on the field, laying on the backboard, stretcher, gurney, whatever it is, so in the supine patient, that's where this examination is most useful. Now, if you were to look in one of the 4 views, the best view to spend the greatest amount of time and the view that you never want to skip is going to be the right upper quadrant view. Now, when you look at the FAST examination evaluating for intraperitoneal free fluid, if you go to the right upper quadrant view and only the right upper quadrant view, you will have a sensitivity of 80 to 85% all by itself, skipping all the other fields. Now, the reason that this happens is the way that we are built. The right pericolic gutter is deeper than the left pericolic gutter. And so if you are going to lay on your back, either on the field, the turf, the gurney, whatever, if you're laying on your back and if you have free fluid anywhere in your abdomen, the chances are, due to the laws of physics, it's going to sink to the bottom of the deepest spot in the abdomen, and that is in the right pericolic gutter. There's a potential space in the junction between the right kidney and the liver that is called Morrison's pouch. Now, in normal, healthy humans who do not have free fluid in their abdomen, there is no fluid in Morrison's pouch. You just have immediate juxtaposition of the parenchyma of the right kidney with the inferior portion of the liver, and you have no black fluid. So for the FAST examination, the goal is to be looking for black. Now, the one caveat is that the gallbladder, if they haven't had a meal in a while, will be a nice circular black structure. The difference is free fluid is always going to be pokey and pointy because it's dissecting potential planes. So sometimes you might see a nice, perfectly round gallbladder. Don't worry about that. That's the gallbladder. You're looking for pokey, pointy, black fluid dissecting potential planes, and that's going to be your free fluid. Here's an example of a scan of the right upper quadrant. And what you see here, you see right kidney, you see the liver, you see the diaphragm, nice, bright white fiber structure here. And it's very clear that you see this fluid dissecting between the plane of the right kidney and of the liver. This is a positive FAST examination. Now, it's important to know, as soon as you see free fluid in the abdomen, it doesn't matter which view you are at, that is considered a positive FAST exam. There's some other finding here that I want to point out. We also have a lot of black over here, black being anechoic, which is fluid. So you have fluid above the kidney, above the liver, above the diaphragm. That means that you are in the thoracic space. This is a pneumothorax as well. One really nice sign on this scan that you can see is called the spine sign. So you see the spine right in here. Normally, it is impossible to visualize the spine and the thorax when viewing from anterior to posterior. And that's because normally you have healthy lung filling up the thorax, and all the air within the lung is going to block the transmission of your sound waves, and therefore block the ability to visualize the spine. So when you have a spine sign, you have fluid in the thorax. In the correct setting with a previously healthy patient who has blunt torso trauma, you can have confidence in calling this a hemothorax. Moving over to the second view, the left upper quadrant, you can see that any free fluid, either between the kidney, the spleen, or the diaphragm, is going to be considered a positive FAST examination. It's important to know that the spleen is much smaller than the liver, and it sits much higher in the abdomen. So it's oftentimes protected by ribs. And so on this study, you're actually going to need to put your transducer a lot more posterior and superior on the body in order to visualize the interface between the spleen and the kidney. And it's just as important to visualize the interface between the spleen and the diaphragm on this view as well, because blood can collect in those two places equally. Now, the spleen is the most commonly injured intra-abdominal organ. However, even with a splenic laceration, you're more likely to see blood in the right upper quadrant due to the right pericollicutter being deeper than the left pericollicutter. The third view is going to be the suprapubic view. And in this view, you're going to look for the urinary bladder. You're going to try and find free fluid outside of the urinary bladder. You're going to sweep in two planes, the sagittal and the axial plane, because that bladder can be pretty large and you want to make sure you're evaluating all the potential spaces. Now, in female athletes, they have another organ. It's called the uterus. And you can have free fluid in two spots. You could have fluid between the bladder and the uterus, as well as between the uterus and the rectum. This potential space here is called the pouch of Douglas. It's very important that you visualize all the way down and you can see beyond the uterus into the pouch of Douglas. One note, when you're evaluating a male athlete, prostate can also look a whole lot like a uterus. So sometimes when you're just reviewing images, you can see a prostate that looks like a very, very small uterus. The fourth view is the subxiphoid view. And what you're doing is you're using the liver as an acoustic window to look at the heart from the inferior aspect up towards the superior aspect. So it's a little bit of mental gymnastics here because your transducer is going from inferior to superior, whereas your screen is showing inferior to superior in this direction. So if you're looking through the liver, the first structure you're going to see is the right ventricle and then the left ventricle here. Now, because this is the most inferior border of the heart, this is the most dependent portion of the heart in the pericardial space. So this is where fluid will collect most commonly due to gravity. Free fluid here is considered a positive FACEP examination for a pericardial effusion. Here's a cine clip showing exactly that free fluid, dissecting the potential space between the pericardium here and then the right ventricle here. Here you see liver and LV. See the nice, bright, fibrous pericardium all the way around. Now, in about 15% of patients, you're not going to be able to get a very good view in the subxiphoid space. And the reason is the transverse colon sits right here, and it sometimes can block your view through the liver as your acoustic window. So it doesn't matter how great of a sonographer you are, it doesn't matter how great your machine is, or how adipose-free your athlete is. Sometimes you will not be able to have an adequate evaluation of this. In that setting, you're going to need to go to a peristernal long axis view. Now this is a view we're all familiar with if you do any form of limited echocardiography. And this is where we're looking for hypertrophic cardiomyopathy, you're looking for ejection fraction, you're looking at your aortic valve, mitral valve. So this is a great view that a lot of sonographers are pretty comfortable with. For your purposes in looking in a FACEP examination for pericardial free fluid, you want to look for fluid dissecting between the myocardium and the pericardium. And it can wrap all the way around. You're always looking for fluid between the myocardium and pericardium. This is one view where sometimes the larger footprint of the curvilinear transducer makes it a little challenging to get optimal intercostal views, and you might want to switch over to the phased array or the cardiac transducer. However, that's not necessary. Here's an example of a peristernal long axis view, and what we see is we see a thin stripe of black fluid here on the anterior aspect, so this is right ventricle, and then here you see left ventricle, and you see more free fluid dissecting between the pericardium and the myocardium. Now, I know what you're thinking. At this point, you've got free fluid in the abdomen. You have free fluid in the thorax and free fluid around the pericardium. That's great. But let's think about most of our trauma patients. A lot of our athletes, extreme sport athletes, or just contact athletes, maybe they're going to have a pneumothorax. This is very common in athletes that have a fractured rib or multiple fractured ribs. So how does ultrasound hold up for evaluating this form of injury? It's actually pretty darn good. Now, on this topic, there are multiple prospective studies looking at this. And not only that, there are multiple prospective meta-analyses looking at this topic. And they all come to the exact same conclusion, that the sensitivity of identifying a pneumothorax with ultrasound is fantastic. So there are sensitivities up to 99%, and on the low end of the literature, it's 86%. And I'll tell you some pearls and pitfalls in a moment, and how you can drive that 86% number up to 99%. And the specificity in the right patient population is pretty darn high. Now we'll go over a couple of patient populations where you can have some false positives, but if we're looking at athletes and doing sports ultrasound and sideline ultrasound, it's darn near 100% specific. What about our good old chest radiograph? Well, time and time again, the sensitivity is shown to be right around 52%. It's kind of the sweet spot. Sometimes it's as high as 60%, sometimes as low as 40%. And the specificity is pretty high. So if you have large pneumothorax in your chest radiograph, you can be pretty convinced that this is indeed a pneumothorax. However, the sensitivity is a lot like going to Vegas and just gambling. Might as well flip a coin rather than get a chest x-ray. In order to do the extended FAST examination, or the eFAST as it's called, you're going to add on a quick view of the lungs. So you're going to do your right upper quadrant, your left upper quadrant, your subxiphoid, suprapubic, and then you're going to go on to your thorax. Now the visualization of rib, shadow, and what you have here is the pleural interface between the parietal and the visceral pleura. You have intercostal muscles, skin, and soft tissue. Now you can visualize this perfectly well with a curvilinear transducer. And in fact, when I'm using the ultrasound and the rapid assessment of an injured or collapsed athlete, I'm using the curvilinear transducer. However, if you have any questions whatsoever on what you're seeing inside the lung, then you can switch over to linear high frequency transducer, because you don't really need a lot of depth. You don't generally have a lot of intercostal and superficial thorax muscle where you're going to exceed the capabilities of 5 to 6 centimeters of your high frequency transducer. Here's an example of normal healthy lung sliding. Now here's our first foam contribution. So this is sonostuff.com. This is put together by Dr. Michael Schick. He's an emergency medicine doctor at University of California, Davis. What we're seeing here is we're seeing normal, healthy lung sliding. It's been described many ways. It's been described as ants marching on a log. I don't know if you can imagine that. It's been described as sliding or scintillating. But what you can sense, no matter what type of action verb you want to attribute to it, that the lung between the parietal and visceral pleura is indeed moving. There is motion there. I want you to also look at one of the artifacts produced by our ultrasound. You see these lines coming down, these little comet tail artifacts, as they used to be called. We now call them B lines. And these are great. If you see these B lines, then you can with confidence say that there is no pneumothorax in this setting. Here's another example with a little bit more depth, and you again see these nice side-to-side lung sliding. And you can kind of see the little ants marching on that log, or those little scintillating components of the parietal and visceral pleura interface. And you see these comet tail artifacts, or these B lines coming down. One other thing that you will see is a form of reverberation artifact, where it's just like when you're on any dense structure, you see it going back to the ultrasound transducer, and then back here and producing a reverberation artifact. So it marches out exactly the same distance time and time and time again. That's normal as well. These A lines, as they're called, those are present in many states of pathology, and they do not ensure normal lung sliding. what we're looking for are these up and down V lines, known as ring down artifact. Now I want to show you an example of a pneumothorax. Now this patient is breathing, you can see chest wall moving, but what we do not see any evidence of side-to-side lung sliding. There are no ants on that log, there's no scintillation, and there are no B lines coming down. You do see the A line, which is just present based upon the fact that they have a parietal visceral pleura interface. So the A line does not exclude any pathology. However, since we don't have any of the B lines, we don't have any of the side-to-side sliding, we don't have any of the ants marching on a log, this, in the right setting, we could call a pneumothorax. There's one other modality, and it's a little bit of a pro maneuver if you want to do that. You can drop an M-mode cursor on this interface right through the pleura and see if you have a distinct change in appearance. And this could assist you in the evaluation of a pneumothorax. So in normal healthy lung, you're going through skin, soft tissue, muscle, and then when you hit the pleura, so we see here we are hitting the pleura, you're going to have motion artifact of the pulmonary tissue produce what's called a seashore sign. So here's a nice example. You have all these waves coming into the beach, and here's the sandy seashore. So that's a pleasant thing, therefore that's your normal healthy status. However, if you don't have normal motion between the parietal and the visceral pleura of the lung, you will not have this beautiful sandy beach. This is called the barcode sign or the stratosphere sign. Now this is not necessary to do. You can just do your good old B mode scanning and have confidence in that. But if you want to play around, you can drop that M mode beam on that as well. There is one ultrasonographic finding that is pathognomonic for pneumothorax. Now my mama always told me, always and never are two words I always should never say. But whenever you see a lung point sign, that is always going to be a pneumothorax. What we're seeing here is we're seeing the intersection, the junction of where you have normal healthy lung sliding, and then right here at this point there's no longer any evidence of normal healthy lung sliding. This is the lung point, and you can see with respiration it's sliding to here, whereas the air is staying on this side. So this is an area of no pneumothorax. This is the area of pneumothorax. This is another foam resource, www.5minutesono.com. This is put by a fellow ultrasound fellow of mine when we were going through our training together. He is now at the University of Tennessee Pulmonary Emergency Medicine, puts together a fantastic 5-minute clips of really great ultrasound findings, Dr. Jacob Avila. Now all of this is pretty great stuff. It's so great that it's endorsed by the American College of Surgeons and is a component of the advanced trauma life support. So this is not just me being a crazy Yahoo. This is something that has been fully endorsed in the use of evaluating the traumatically injured patient. Now, I'm sure some of you who are pediatricians or sonographers that don't have broad training in trauma, maybe even some family medicine residents or PM&R folks, I'm sure some of you are a little bit hesitant to utilize this. And I want you to have confidence that web-based learning of the eFAST is just as good as hands-on training. There's this great study of 2 European hospital systems showing that you absolutely can indeed learn the eFAST just from online learning resources. That's the eFAST examination, and that's very, very cool. I wanted to throw in one extra little tidbit because I don't know about you, but with me and my athletes, we're constantly traveling to high altitude. Sometimes we're working ski clinics, sometimes then covering events up in the mountains, so 7,000, 8,000, 10,000 feet. And for those of you in Europe, I'm sorry, I don't know what those are in kilometers, but I think it's a lot of kilometers. One other great way that I use lung ultrasound is to evaluate for the finding of pulmonary edema. So in the setting of high altitude pulmonary edema, this is a fantastic tool. It's much more sensitive than chest radiography. What you're looking for in the setting of pulmonary edema is the presence of multiple B lines. So here, Remember, we have these ring down artifacts, and these are normal. So it's normal to have 0 to 3 of these in one interspace, one rib interspace. When you have a whole bunch of these B-line artifacts, then that is suggestive of increased interstitial edema. So here we can count them out 1, 2, 3, 4, 5, 6, 7. So we have at least 7 here. This is absolutely positive for the presence of increased interstitial pulmonary edema. So this could be either a cardiac contusion, this could be a pneumonia, it could be high altitude pulmonary edema. So it depends on your clinical setting. I remember when I was working up at Snowbird Ski Clinic, there was a ski patroller who he said that he always had altitude-induced asthma. So every time he came up in the wintertime, he always had really bad asthma for about 4 or 5 weeks, and then his asthma got better. But when I saw him, it was his worst, quote-unquote, altitude asthma ever. And so I did an ultrasound, and he was in florid high-altitude pulmonary edema. So this is a great skill set to have, particularly if you're ever traveling. So if you're ever going to Utah, Colorado, Montana, Wyoming for some of your contests, this is a great one to have in your back pocket as well. That's going to conclude our talk on the FAST and eFAST and the pulmonary ultrasound. I want to throw in a couple of other really, really great uses of the sideline ultrasound. Here at UC Davis, we have a phenomenal viticulture and enology program. So what that leads to is a lot of really dehydrated, hungover professors. No, I'm kidding, it doesn't. But this is, fluid status is fluid status. And so what I want to do is I want to show you a couple of great tools that you can keep in your back pocket for evaluating the collapsed athlete to try and differentiate what it is that's causing them to be in distress. Is it purely hypovolemia? Is it hypoglycemia? Is it pneumothorax, pericardial effusion? All these things that you need to think about when you have a collapsed athlete or a distressed athlete. Here in this study, they show that just using basic bedside ultrasound or bedside ultrasound is going to be just as useful as a fluid responsiveness indicator as all of our CVPs, pulmonary artery wedge pressures, and then these other more advanced imaging modalities. So how do you assess for this? You're going to put your transducer on the abdomen where the inferior vena cava is. Now, the inferior vena cava has a great degree of responsiveness to your fluid. So if you are very well hydrated, your inferior vena cava will be robustly full. And if you are very severely dehydrated, your vena cava will collapse. It's very dynamic, and it's in real time as well. It's important to remember that your vena cava lies on the right side of your intra-abdominal cavity. So you're going to put your transducer several centimeters on the patient's right. And on this setting, I want to utilize the curvilinear transducer. This is going to give us excellent footprint, nice broad footprint, as well as good image quality. We're going to use our liver as our acoustic image, and the probe indicator here is towards the patient's head. And so what we're seeing here towards the patient's head is going to be the right atrium. What you see is the inferior vena cava coming into the right atrium. We're using the liver as our acoustic window. If you can identify the hepatic vein draining into the inferior vena cava, fantastic. That is great. That's the landmark you want to look for. However, if you can't visualize the hepatic vein draining into the inferior vena cava, that's okay. Just go approximately 2 or 3 centimeters from the right atrium and measure this distance here. We're looking at 2 things in this image. Thing number 1 is the presence of fluid. So yes, there's lots of fluid. And number 2 is the presence of collapsibility with respiration. Now, if you have them do what's called a sniff test, where you have them take a big breath in quite quickly, what that's going to do is that's going to cause collapse of structures within the abdomen. And if they are fluid down and they don't have much fluid in their venous system, the inferior vena cava will collapse down. Let me show you an example of that. But before I do that, I'd like to point out one other foam resource, free open access medical education. So this is EM-Crit podcast. This is put together by Dr. Scott Wendart, who's over at Stony Brook. He has a lot of really great ultrasound-related podcasts. Moving on to an example of a collapsed inferior vena cava. Here the image quality is a little bit lower, but what we see on the left of the screen is the right atrium. And then we're not really clearly seeing the hepatic vein coming into view, but that's okay. We're just going to look 2 or 3 centimeters over. We're going to evaluate the distance here. Now, as far as measuring the distance between the two, that's not as important. Now, the American Society for Echocardiography, ACE, they do have really great guidelines when you measure the inferior vena cava and you measure the amount of collapsing with inspiration to estimate central venous pressures, or CVPs. And that's fantastic for critical care physicians, for emergency medicine physicians. But I think that on the sideline, when you're in the tent at a marathon, knowing their exact CVP, whether it's 5 or 12, is less helpful than knowing, are they dry or are they wet? So here's a quick evaluation of side by side, nice and full with fluid. We don't need to give them extra fluid. We don't need to start a line for them, and not a lot of fluid. Just so you have that, I want to give you this other phone resource. Discover Echo is a fantastic website that really goes through all the basics, and it's very, very palatable. For even someone who's never read about echocardiography, this is a great resource. But this table is from their website, and measured in centimeters, if you have a itty bitty vena cava, let's say it's under 2 centimeters, and it is just collapsing, well then of course they're going to be volume depleted. And then as you increase the size of your inferior vena cava over 2.5 centimeters, and you're not having any changes of the size or diameter of your inferior vena cava with respiration, then you're fluid overload. Oftentimes, your normal athletes are going to be in the normal zone where they're going to be collapsing their vena cava maybe 20%, and it's going to be about 2.5 centimeters. In the marathon setting or the endurance setting, it's really nice to take a look at that vena cava, and if it's under 2.5 centimeters and it's collapsing, then that person needs more fluid. Moving on to the use of ultrasound in the setting of other traumatic injuries, I use ultrasound first line management in all of my orthopedic evaluations. And so I use this prior to x-ray, and I'll actually make decisions on whether or not to obtain an x-ray based upon my ultrasound findings. Now, I encourage you to check out Dr. Hoffman's review on ultrasonography of fractures in sports medicine. I think this paper came out in 2015, but it's just a good one. It goes over all the basics, goes over normal sonal anatomy, as well as the various pathologic findings, false positives, as well as false negatives. I want to show you a couple of specific examples. What we're looking for is we're using the ultrasound on long bones as well as short bones, but the key is they have to be flat bones. It's really hard to evaluate subtle changes in the smooth cortex of a bone if they don't have smooth cortices on their own. So when you're looking at all the tarsal bones or the carpal bones, and these bones that have a lot of unique anatomy, there are going to be a lot of little bumps and lumps on these cortices that are totally normal. So try and use ultrasound on bones in areas that you know ought to be smooth and flat. So this is an example of a fifth metatarsal, diaphysis to metaphysis right here. And here we see, this is an area of tenderness, we see a bony callus. So this is a bone stress reaction that is forming here. And one thing that's really fantastic with ultrasound is you can use what's called sonopalpation. And so if you can go exactly to the area of tenderness, and sometimes I have the athlete place the transducer on the area of maximal pain, and then we can scan right there. And we can just visualize, really hone in on the exact spot of pain. It's really, really helpful. Here we see a rib in long axis view, and you see a bony callus formation here. So this is evidence of callus formation from a prior stress fracture. And then here is a case where we had a femur fracture, and it was really helpful to do the body habitus because it wasn't obvious on physical examination. Now, the Frederickson classification on bone stress reactions comes into play in our evaluation of bony cortices. So on Frederickson classification 0 and 1, where the cortical changes are very, very subtle or absent, you're going to have a normal appearance of an ultrasound. However, as you climb into Frederickson grade 2, grade 3, and 4A, where you have clear cortical changes and periosteal changes, you will be able to see bone stress reactions on ultrasound, which is just, I mean, it's just fantastic. One thing that's helpful is that in rib fractures, classically chest radiographs are going to be negative. Non-displaced rib fractures. There's just too much curvature of the rib to really catch that fracture. So doing an ultrasound of ribs has been proven to be a superior imaging modality than radiography. And here we're going short axis over rib, and you can just see callus, bony callus right there. Moving on to tendon evaluation. Now these are slides that are borrowed from my colleague and mentor, Dr. Madera Call from the University of Iowa. These are slides that he put together for a fantastic talk in 2017 for the AMSSM. This is his piece on tendon rupture evaluation. Now, I commonly will see Achilles in my athletic population, but you could also use this for evaluation of any tendon. But we'll go through a lot of nice Achilles tendon views. I mean, in most structures in the human body, you're going to want to visualize in 2 axes. In ultrasound, we commonly say long axis and short axis. If you're speaking to surgeons, sometimes it's useful to break it into more familiar nomenclature, such as sagittal, transverse, coronal. But here, we'll just use long axis. So if you place your high frequency linear transducer in long axis, commonly what we do in ultrasound is we'll place the more proximal structures on screen left and the more distal structures on screen right. However, depending on the bed and the patient, where your ultrasound machine is, just make sure that the image that you're seeing is matching up with how your patient is positioned. But if you have the luxury to do this, proximal will be screen left, distal will be screen right. What we see here is beautiful, normal, healthy Achilles tissue. This is just fantastic. Some people describe this as finely combed hair or fine copper wire. So you just get a nice look at the echotexture of normal, healthy Achilles tendon coming into calcaneus here. Now, as we move into the short axis and move our transducer 90 degrees, what you see here is Achilles tendon here. And you see these beautiful little stipulations. Almost looks like you're looking at a paintbrush head on and you're seeing all the little bristles. So this is normal, healthy tendon appearance. Now, partial ruptures will be presented as loss of that beautiful, normal, healthy, finely combed hair or fine copper wire appearance. And you get a little bit more of kind of a washed out appearance, and that's going to be edema, acute edema within the tendon. And it almost looks like someone just took their thumb and smudged it a little bit. Here you see in hypoechoic fluid, this is blood from the partial rupture, and then in short axis, you're again visualizing the same changes. This is a nice visualization of the Achilles tendon with a complete rupture. So here you have a still image, just absolute complete fluid interposing the distal and proximal portions of the tendon. And then here we're going to do a dynamic examination where plantar flexing and dorsiflexing the patient's foot, and you see the 2 stumps of tendon absolutely moving away from each other, interposed with fluid. And you see a lot of black, which is going to be the hypoechoic liquid fluid, as well as some schmutz, and that's going to be some of the coagulated fluid. Deep to this, you have the flexor hallucis longus, and depending on where you're visualizing the Achilles tendon, you can sometimes see the plantaris tendon deep to it, and if you're moving a little bit more medially, you can sometimes see the FHL tendon deep to it. Please don't confuse that as a partial or incomplete Achilles rupture. So you're going to want to slide your transducer medially and proximally to really visualize all the structures nearby. But that is a pitfall. Sometimes people will call it FHL or plantaris tendon as an incomplete Achilles, when indeed it is a complete one. Now, I think no ultrasound talk that is discussing tendon is complete without bringing up the possibility of anisotropy. Now, anisotropy means without sotropy, and sotropy is being non-directionally dependent. So an example is the sun is isotropic. That means that it sends its warmth and sunshine in all directions. Whereas a flashlight is going to be anisotropic. It is directionally dependent. You only get light where you're pointing your flashlight. So if you are pointing your ultrasound transducer perfectly perpendicular to any dense structure, whether it's tendon, nerve is a big one as well, bone, you can even have anisotropy on bone, any dense structure, if you're perfectly perpendicular, then all of your sound waves will bounce off of that structure, come back to the transducer, and the image that you have on your screen is going to be evaluation of that beautiful structure, and you see it. Now, if you are not perpendicular to that dense structure, your sound waves are going to strike the structure and go on and go away from the transducer. Since there are no sound waves coming back to your transducer from that structure, it will appear black or hypoechoic, and that's anisotropy. So it's important whenever you see an anechoic or hypoechoic structure when you're doing a musculoskeletal ultrasound, that you rock your transducer. You move it around to attempt to become perfectly perpendicular to that structure, in this case, the long head tendon of the biceps. Because if you have black that does not go away as you're rocking your transducer, then you can be confident that that is indeed fluid and a sign of pathology. Whereas if it comes into view as you're rocking your transducer, well, then that's just normal sonoanatomy. That's just normal physics at play. Let's talk about ocular emergencies as we're closing this talk up. I think this is fantastic. It's so common for athletes to have a huge swollen black eye, and you can't even evaluate the globe. It causes a lot of distress if you don't have an ultrasound. Now, I know what some of you are thinking. Are you kidding? You're going to ultrasound the eye? Is there even any data? Well, there's fantastic data on this. And actually, the eye, of all the things I've talked about, is one of the best things to ultrasound. Sensitivity for vitreous hemorrhage and retinal detachment is 100%. Now, I'm not a statistician, but I feel like sensitivities of 100% are pretty darn good. Specificity of 92%, positive predictive value of 62%, negative predictive value of 100%. So what are we going to do on this one? We're going to select the high frequency linear transducer because we want very crisp images, and they're all superficial. None of them are going to be greater than 5.5 to 6 centimeters in depth. We're going to have the patient close their eyes. And you guessed it, we're just going to put the ultrasound jelly straight on their eyelid. Some people are kind and will put tegaderms down. Sometimes they'll fill a bag with water, and they'll place the water down there, and then you can have an acoustic standoff bag with the fluid. This is so easy, and I've had so much ultrasound gel during my ultrasound fellowship and my sports fellowship. I'll just tell you, it's not irritating. It's totally fine. It rinses right out. It's not a big deal. This image I got from Dr. Ma and the Vitreous Emergency Ultrasound textbook, which I think is a fantastic resource if anybody's looking for a hard copy of some of the stuff we talked about today. Step number 3, you're just going to put the end of the transducer right on that gel. One thing that's important is you absolutely want to anchor your hand onto some part of the patient's body, whether it be forehead, maxillary ridge, nasal bone, something. You want to be able to float your transducer in that ultrasound gel, because if they have a globe rupture, pressure upon the globe is not good. And even if they don't have a globe rupture, and they just have a normal eye that you're ultrasounding, putting pressure on it is uncomfortable. I wouldn't recommend it. This is yet one more foam resource, Daily Emergency Medicine. They have great images and information that's open and access to everybody. Quick sonoanatomy. So if you are transducing the eye, we need to know what we're looking at. So just a quick refresher, you're going to have eyelid and skin and soft tissues up top. The first thing you're going to see is going to be the anterior chamber. And if you line up perfectly, you'll see the pupil. It's so cool. And one thing you can actually do that is amazing is if you are ultrasounding the left eye, and then if you shine light into the right eye with ultrasound, you will watch the irises move inwards, and you will actually see pupillary constriction. The next structure we're going to see is going to be the lens. We have our vitreous humor, and then on the very back of the eye, we're going to have our optic nerve. and we'll talk about some optic nerve stuff in a moment as well. One thing that you can see and can see with great confidence is going to be a vitreous hemorrhage. What you see here, we didn't do a very good job of lining up on the very, very front of the eye, so we're not seeing the beautiful structures of the anterior chamber, the ciliary bodies, the pupil, or the lens. So we're off axis on that, but what we are visualizing is multiple hyperechoic structures moving within the vitreous body, and that's consistent with a vitreous hemorrhage. Deep here, you'll be able to see optic nerve. This is going to be an example of retinal detachment. Whenever you have a thin, fine line coming up off of the base of the globe, that is the retina that has become detached. This is very sensitive for identifying retinal detachment. Here we're a little bit off axis and we're just seeing some anterior chamber here. And you see nice clear vitreous body, so there's no retinal, there's no vitreous hemorrhage, but you do have the retinal detachment. Finally, we're going to cover a lens dislocation. Here we're going to have the ciliary body here, anterior chamber. This is going to be our vitreous body. We don't see optic nerve in this view, but you see the lens has become dislocated deep to the ciliary body, which is normally held up there. That is the end of my sideline ultrasound talk. It was quick. Lots of information. I encourage all of you to email me with any questions, comments, or concerns. You can email me at jwray@ucdavis.edu, spelled out ucdavis.edu. Thank you so much for your attention, and thank you so much for your time.
Do we have any questions from the audience? Wait a few seconds. Okay, well, oh wait, here we go. See? Yes. Dr. Ray, I'm going to grab the screen from you so I can show, we're getting questions about your email address.
Oh, yeah.
So his email address is on this slide. And do we have any questions for Dr. Ray before we finish? Okay, well, thank you very much, Dr. Ray, and on behalf of the AIUM and the AMSSM, our thanks to all of you who participated in today's webinar. Please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. So long, everyone.